So usually, it's been documented, girls with AIS have a reduced BMI. There have been some concerns about a correlation, possible correlation between this low BMI and eating disorders, but a study that we recently published showed that, at least in Italy, in our population, there is not such a connection. And from this study on, we developed some interest in the physical features of AIS patients, both for the aspects of treatment that may be for etiology. And even if usually girls are quite slim, there are also girls with AIS and increased BMI. And according to a study of O'Neill of 2005, an high BMI is a negative predictive factor for brace treatment. In his paper, he found that being overweight increases 3 times the risk of a failure of the treatment, with a high percentage of patients that got fused. So the objective of our study was to verify if also in our population, in our clinical practice, there is this correlation, this negative effect of BMI on the results of brace treatment. So we designed a retrospective cohort study in which we included a population of 351 AIS patients, most of them were females, aged between 10 and 15 at the beginning of the treatment, an average of 12.9. The average worst curve was about 35 degrees, and the 8-year 11, and the median risk was 2. The BMI was 19.7. This population was made by a group of 152 patients that already completed the treatment, and another group of 199 patients who were close to the end of treatment, since they were wearing the brace only at night and were at risk 4 or 5. And what we did is to analyze data from both this group together and separately to seek for possible differences. And all the subjects included were prescribed initially a brace treatment at the first visit at our facility, and the initial prescription were at least 18 hours up to 23 hours per day, accompanied by a SEAS exercise protocol. And then, according to our protocols, the brace, as Stefan said before, the brace hours were progressively reduced. The outcome measure were the number of patients improved or worsened, defined as a change larger than 5 degrees, stable in case of a lower change, the average change of probe angle, the number of patients over 45 degrees. And for the analysis, we corrected the height for the loss due to the curve according to the Stokes formula. And the calculation of the overweight was made according to the 85th percentile, as it's currently used in this field. For the statistical analysis, we used the chi-square test, the Pearson correlation coefficient, and a stepwise linear regression to control for possible confounders. So, as you can see from the graph of the Pearson correlation, there was a trend toward a better results when the BMI goes up. Despite being statistically significant, this correlation was really poor, being only of 0.16, so it's not clinically relevant, it's not a real correlation. Taking into account the patient changed, in the overweight patients group, we had 7% of worsened and the same percentage in normal weight, and the differences, as you can see, are not significant. The patients over 45 degrees at the beginning of treatment were 28% in the overweight group and went down to 21 after the treatment, and were 19 and went down to 9 in the overweight, in the normal weight group. And also this difference is not statistically significant. For the compliance, we calculated the median value, as you can see in the graph. It's quite stable as the BMI changes, so this data probably is quite different from previous data, and even if this compliance was only referred compliance, it was not checked with the thermobrace, we can rely on this since this is a sample of our patients, quite standard. And performing a linear regression to seek for possible confounders, we used initial Cobb angle, the research sign, the age, the sex, and ATR to try to build a model, but the R square was just 0.13. So our model is really not predictive of progression. And this is an important point. These are the most relevant things that we consider usually when making a prescription. So according to our data, BMI did not predict a negative result. We have the same results in both populations. And performing the analysis in both the completers and those who were closer to the end of treatment, we had no differences. Compliance probably reduces by mechanical limitation of the brace. In our population, the average was of 20 hours a day of brace at the beginning, progressively reduced, while in the O'Neill study, both the groups referred 14 hours a day of brace. So probably when the hours go down too much, there is an impact of BMI that it's masked when the patients were much more the brace. And BMI, the research sign, age, initial Cobb angle, ATR, sex, and altogether predict about 13% of the result only, so not so much. There are other things that we don't know that we must look for to understand what would be the final result. Thank you.